I'm excited to talk about our work looking at infantile spasms and how it progresses to LGS. And so most of the research we do is focusing on the EEG and focusing on EEG-based biomarkers. So my only relevant disclosure is that I'm funded by the group that's throwing this lunch, so thank you. And I'm excited to show you some of the stuff that's coming out of our work there. So, speaking last, probably all of this has been touched upon at some point, but a little more about spasms is that, we see spasms that typically onsets within the first year of age, most commonly between 5 to 9 months of age. And, LGS, like we've seen, between 18 months and 8 years is probably the greatest period of onset there. So there is this window in between the two, which we heard earlier is around 1.9 years or so of this evolution that happens. And one of the questions that I think is important is whether there are ways we can see this evolution starting to move in the direction to LGS, and then if we can, ultimately intervene on that and do something about it. So just visually, when we look at the EEG, a lot of our kids that have spasms, although it is variable, we can see the hypsarrhythmia pattern, classically described as chaotic, spikes that occur unpredictably in 1 second to the next, things change. But knowing that there's multiple versions of this, right? There's classic hypsarrhythmia, there's modified variations. And then we're pretty good as pediatric epileptologists on agreeing is there hypsarrhythmia or not, but in terms of grading it, how is this one worse than the other one? We've historically not agreed so well. And so a lot of work's been done with the base score and the revised base score to try to standardize how we can clinically grade the EEG in our kids with spasms. And then the question is, we see this chaotic pattern evolve into the slow spike and wave pattern of LGS. And to us, and I think to everybody, we ask the question, is this really the same network? Is this the same process that just manifests differently in an older, more developed brain? Or is this something different but related? So we use one of our main metrics we use is called functional connectivity, and most of you are probably familiar with this. This is a way that you can mathematically look at each pair of electrodes on the scalp in this case and determine the strength of the connection between them. When one moves one way, does the other one move in the same direction or not? And this can allow us to generate a connectivity map like this. I'm very excited to see that someone else put up a functional connectivity matrix before me so that this is now you all know what this is, right? So each row and every column is an electrode, and the color corresponds with how strong the connection is over the duration of the EEG that you're looking at between those two electrodes. And so one of the things we found when we looked at infantile spasms was that when you look at healthy infants and you analyze their networks as a group, you get A up here, this control group, where you have this bifrontal and occipital network that's of a lower level of connectivity compared to the kids when we see pre-treatment spasms. These are all new onset spasms. We can see a lot higher strength connectivity in the same network as the controls. And then we also see these longer range, frontal to parietal, right? Similar to kind of some of the LGS networks we've seen, connections before they're treated with medications. Among this group B, those who responded and had resolution of hypsarrhythmia and spasms, their post-treatment networks look very similar to those of controls, and in fact, really statistically are indistinguishable. Among those who did not respond, many of them, their networks moved towards controlled networks, but there was still, as a group, persistence of some of these long-range values. What we did was we looked at the total number of significant connections in here, and that gives us a number to apply to this. So I don't know if you can see this, I'm kind of standing right in front of it, but we found that the dots that you see in black on the left here are pre-treatment spasms who responded, and interestingly, there's 6 really high level of strength networks or patients who responded quite well. Those 6 actually did not relapse, they did really well, they didn't go on to LGS. The red dots are non-responders, and what we found was when we looked at which way their networks moved following response, 3 of those kids actually got stronger networks after responding. Everyone else of these 21 subjects, their network strength went down after being treated with ACTH or vigabatrin. And so that brought up the question of, is this network strength a potential indicator of evolution from spasms to LGS? So this is some work done by Virginia Liu at Children's Orange County and Blanca Romero at my wife's lab at UC Irvine. And so we looked at the time of diagnosis, this is one kid, what does the network look like when they're diagnosed with spasms? And then how does that network change as they go on? So this particular kid was treated and had improvement in their spasms. And you can see, based on the structure of these network, these kind of colorful, brighter spots here are going to be the stronger nodes within that network, the stronger connections. Those connections are still present a month and a half later when they were re-recorded. And then when they had LGS diagnosed at 19 months of age, we see really the same kind of connections. Those same networks are still at play. They just are much stronger. And then as you know, this child was treated for LGS and we had some trouble with controlling seizures, those networks just persisted and got stronger and stronger over time. And this particular patient had very difficult to control seizures and more severe neurocognitive consequences. So one of the things that then we looked at was, well, what happens across the board? So this is a picture of the different networks that we see in kids at the time of spasms diagnosis in kind of this orange color, and then also at the time of LGS diagnosis. And one of the things that I think is important to point out, that if you look at the kids when they get diagnosed with LGS and we start treating them more aggressively because of that, we can see that in those kids who are effectively treated for LGS, the level of their, the strength of their functional networks decreases with successful treatment. Another way to look at that is this. So these are the 2 time points here, IS diagnosis and LGS diagnosis. And we can see that at IS diagnosis, these kids are universally put on an aggressive therapy, usually ACTH, but sometimes vigabatrin or prednisolone. 4 out of the 5 patients after that treatment had improvement in their connectivity closer to normal levels, but all these kids eventually went on to get LGS, and you can kind of see that their connectivity strength started trending upwards prior to the time point here where they were actually diagnosed with LGS. So the question is, if you see this happening, even though, like Elaine mentioned earlier, a lot of the times you see the EEG and you see these kids and you know they're moving in that direction, but they don't yet meet criteria, can you intervene here? Can you become more aggressive and treat it here to keep them from getting to the point that they eventually move to LGS, or has that ship already sailed by this point? I don't think we know that, but I think this is potentially a way for us to identify a way to find these kids and then intervene more early. Additionally, on the front end of things like the Epi-Stop and Prevent trial, are there connectivity measures that start ramping up before the IS diagnosis that we could more aggressively jump on and prevent even the emergence of IS in these kids and prevent this whole cycle from starting just to begin with? We also look at other measurements beyond functional connectivity. We looked at amplitude topography, meaning where on the surface of the brain are the amplitudes of the EEG highest, lowest, etc. And on the left, you can see this is as a group, a series of LGS patients that had much higher amplitude in kind of the frontocentral derivations, whereas other patients with epilepsy, not healthy controls, really don't show this similar pattern. Some of this may be due to some of the slow spike wave and other things we see that we know can be bifrontally predominant, but again, just as an objective measurement, can be pretty convincing. And then the last thing I wanted to talk about is some work done by Derek Hu in my wife's lab, and I don't have his picture here, but he's sitting over there, so come visit his poster later. So what Derek has done is taken among our kids with LGS, their EEGs, and he has found a way to use time frequency analysis to identify areas within the EEG that show abnormal features. And there's different features that we use to look at this. We look at the height of these blocks of features. We look at how long or the width these features last, how many electrodes are involved with these features, the density, meaning how many values are present across all frequencies relative to the width and other things. And this is just a way that we can objectively and kind of autonomously identify interesting waveforms in the EEGs of kids with LGS. So the goal here was to say, okay, can we find a way to algorithmically pull out the GPFA, the slow spike in wave, the tonic seizures, and other things like slowing or other things that maybe visually we're not good as epileptologists at identifying. And so after that is done across all these patients that we're analyzing, we use a clustering method to look at these 6 features and to say, let's look at where there are clusters of features where a lot of kids have the same thing that have LGS, if that makes sense. So among the kids with LGS, which ones have a certain duration of an event, a certain frequency of the event, and then we can form these clusters and say, okay, there's a bunch of kids that have this kind of event, another bunch of kids that have this type of event, and then we can look and see how good this clustering matches what we clinicians say, and if it matches their outcomes. So this is just a graphical representation of some of the features of these different clusters that were pulled out. And then at the bottom, it's maybe a little hard to see, are when we had epileptologists review them, we had them look at what do you think this particular event was in this particular EEG? Was it slow spike and wave? Was it GPFA? Was it nothing? And so what we found was there are certain clusters that really do match clinical things that we know are important in LGS, right? So this cluster 1, for instance, these are events that last a long time. They have a very broad frequency component, and this ended up being 100% concordant with epileptologist reviews saying that these are slow spike and wave trains, right? Cluster 2, for instance, 44% of the reviews said that those look like GPFA, 25% look like slow spike and wave, and so the kind of correlating what we see clinically with what the computer sees is the point of all this. And then when we look at these clusters, the ones that are marked in green are the ones that are significantly found within each individual patient. So the LGS kids are the ones where the box is lit up here. And for the first 5 clusters, you'll see that those clusters are significantly seen in the majority of the LGS patients, 16 out of 20 of them, and only in a couple of our control patients, which are people with other types of epilepsy. So this is a way that we can potentially objectively measure some of these interictal variables that maybe could clue us into the severity of LGS at any given point. Using the first 5 clusters together, trying to separate controls versus LGS kids appears to be pretty significantly easy to do with p-values less than 0.001. So, and this is again completely objective. We just have the computer cluster these things and tell us where the separation is. So using something like this, you could potentially put in an EEG of only 10 minutes of sleep data, and it could tell you from those 10 minutes of sleep data, does this patient most likely have LGS or not? And potentially, depending on other things that we're working on, could tell us how bad is their LGS, so that's something we haven't quite tackled yet. So really the goal is then to take these potential biomarkers and validate them across all sorts of types of epilepsy, all sorts of patients with LGS, and then also correlate them with outcome, right? So if we say clusters 1 through 5 are very tightly correlated with poor outcomes, if they're above 60%, for instance, then that would be really helpful, and it would tell you that perhaps you should be thinking about neuromodulation or other things if those clusters start moving in the wrong direction. So really, things that we hope to do moving forward is to broaden the scope of the phenotyping we do in terms of our computational metrics, and then if we do find something that we can validate, integrating it into our clinical practice, right? Using that validation or using those biomarkers to determine what to do with your patients. And just thanks for everybody who's contributed to this, and thank you for your time. plus a shameless plug for our posters.
So a question, maybe comment, is I know we looked at magnetic encephalography, looking at connectivity and looking at different bandwidths. And with that, we were able to look at kids with TSC and predict highly accurately which ones would develop autism long before you can make a clinical diagnosis. Have you guys looked at different even frequencies beyond just the connectivity to see if other aspects, and I don't know, maybe that's down the road, but behavior, cognition, anything correlates with improvements, not improvements, those other aspects of the disease?
Yeah, that's a great question. Most of our functional connectivity is done using just the broadband at this point. We have done some work looking at the networks within the different frequency bands. We're still in the process of aggregating the outcome data, and being a retrospective study so far, that's probably going to be a little shaky, and I think a prospective look would really be helpful to know that. But I think that's exactly where we hope this stuff goes.
Yeah, because in my mind, I mean, much like yours, it makes perfect sense to start to include biomarkers and high-density EEG, looking at bandwidth and connectivity. You can even get on these kids, because you said the kid could be squirming the whole time, but you just need to get 5 or 10 minutes out of an hour where it's not obliterated all with movement artifact, and you can do all this, and you can get that on even some of these really challenging kids for the most part. So it'd be a great biomarker to add to all the studies we're doing, whether it's pharmaceutical, device, you name it.
Yeah, absolutely, and I think of it as an add-on, right? It's not going to in any way replace our clinical appraisal of the EEG, but it's just one more piece of data we can include into our calculus when we decide what to do.